about patient autonomy, advanced directives, medical proxy, and what we normally call do not resuscitate or DNR orders. Welcome and feel free to interact with us as we do this session. And to help us unpack this, subject matter, we have with us our very own Dr. Esther Nafula. She's a palliative care and pain specialist at Kenyatta National Hospital, and she's also the head of unit palliative pain and palliative care unit. She is a medical doctor. She holds a master's in science and diploma for higher education in palliative care from University of Oxford. And she is passionate about advanced care issues, palliative care and pain management, and support in psychological issues during end of life care. She is a trainer in palliative care. She has volunteered in many areas in this country, and would welcome her to share with us what she knows about advanced care planning, which is a new area within our domain. And would wish to welcome Dr. Esther to come and take us through.
Please stop sharing the screen so that I can share my screen.
Okay.
Okay. I'll be able to share.
Okay.
So this afternoon, I would like to take us through the journey of advanced care planning, how it all started, why it is important for us to know about advanced care planning, and basically where we are in Kenya and the models that are being used about advanced care planning. So when I think about advanced care planning, I like to think about it from a personal point. If I was ever incapacitated, I was too sick to make a decision for myself, I was involved in a tragic accident, what kind of care would I want for myself? Would I want to be put on a life-sustaining therapy? Would I want to be intubated and stay on mechanical ventilation when I'm brain dead? Those are the kind of issues that we look at when we're thinking about advanced care planning. So it's actually planning ahead for future healthcare decisions. If there is a sudden unexpected event, a heart attack, a car accident, a stroke, someone is unable to communicate and we do not know what their wishes are, who would be there to communicate for them? And would those decisions actually reflect what the individual wants? If I was in persistent vegetative state, would my family know what kind of decision to make when the doctors ask them, should we intubate her? Should we resuscitate her? Would they know what my wishes are? That is what advanced care planning is. So we'll break it down, because advanced care planning is a process. It has a set of things or documents that are used for the process, but the issue is about discussing our process in case of incapacitation or in case of serious illness. So we'll start by defining the tools that are used for advanced care planning. So an advanced directive is a written instruction that is recognizable by law that relates to provision of healthcare when an individual is incapacitated. So when these wishes are put down in form, that is an advanced directive. So an advanced directive can have a living will, a durable power of attorney, and a do not resuscitate order. Sometimes the do not resuscitate orders are separate. So a living will itself just declares what the wishes are for healthcare, and it includes life-sustaining therapies and comfort care. Then a power of attorney means that I have authorized someone to make healthcare decisions for me when I'm unable to speak or I'm incapacitated. So that person becomes my power of attorney. A do not resuscitate order is issued to an attending physician, and it's about either someone, when their heart stops or they're not breathing, are we going to try to revive them? That is what resuscitation means. So the patient can request to be resuscitated or not to be resuscitated. Now, what I want us to realize as we go along with this presentation is that some of these interventions come together. For example, someone cannot say do not resuscitate and then accept to have mechanical ventilation, because how will they get on the mechanical ventilator without being resuscitated? And it's also important for us to understand the interventions, so that when we are discussing advanced care planning with patients or families, we are able to explain to them in a manner that they can understand. So advanced care planning is very important for very many reasons. But the top three is because as individuals, we have a right to our own choices, and our choices have to be honored. We are working in an era of informed decision making. The patients need to be involved in the process of making decisions about their health. People who care about you are grateful to know what you want in the event you are incapacitated. We get a lot of scenarios every day where we are asking families whether their relatives should be treated, not treated, and some of them don't really know what the individual wishes are. So they end up making a decision as a family, and sometimes it may not reflect what the wishes of the patient are. Also, if we leave advanced care planning to be done later, later could actually be too late. Because when is later going to be? The best time to have an advanced care plan is before someone is unwell, because it's easier to discuss issues of healthcare before a crisis happens. When a patient has presented with a stroke and we are asking the family whether we should resuscitate them, the emotions are high, people are panicking, they do not know whom to consult. So sometimes they actually are not in a mental frame to make the best decision for that patient. So what we need to consider is that discussing and deciding goals of care in the event of incapacitation is what advanced care planning is about. It's about the goals of care. What are we trying to achieve? Is it possible? And does it reflect what the personal values of the individual patient are? What is the culture that the patient comes from? What is their religious belief? And how does it affect the decisions that they make about their treatment? We know that religious affiliations, cultures, they really determine how patients accept or refuse treatment, or some interventions that we may even consider to be life-saving. For example, even blood transfusions. There are some religions that will not advocate for blood transfusion. Therefore, we have to understand where the patient in Kenya, unfortunately, our practice is that we contact the next of kin. So when I get admitted to hospital, I'm asked to fill a form. Who is my next of kin? Sometimes the people we fill out as next of kin are not the ones who will make decisions for us, or we do not trust them to make decisions for us, but sometimes they're the ones paying the hospital bill. So that's why we are naming them as a next of kin. So when we are looking at a decision maker for the patient, a healthcare agent, a medical proxy, who should be the best person to nominate the healthcare proxy? Should we just go and pick the next of kin from the records? Or should we try to inquire what kind of person within the family, or who is it that the patient would wish to make decisions for them? So what we explore and sometimes, yes.
Dr. Nafula,
Yes.
your internet is not stable. We can't get some of your words. I think maybe you check your internet.
Okay.
Yes.
Just a minute. Hello, can you hear me clearly now?
Yes, we can get you clearly.
Okay.
Go ahead. Yeah. Go
So
ahead.
life-sustaining therapies are meant to prolong your life at any cost. So the issue is someone wants to stay alive. So there is the issue of sustaining life versus the issue of comfort care. So sustaining life means no matter what diagnosis the patient has, what the outcome is, what the prognosis is, we try to keep them going, we try to keep them alive. Comfort care means we do what is actually possible within, of course, looking at resources, within the patient's means, the diagnosis, the outcome, the prognosis. We look at all those factors before deciding which interventions are suitable. So life-sustaining therapies are interventions that are used in the event of a medical crisis to try and prolong a patient's life. Sorry about the typing errors. So there are three major interventions that are termed to be life-sustaining therapy in research. So we have CPR, which is cardiopulmonary resuscitation, which refers to cardiac massage, defibrillation, inotropic support, and fixing a tracheostomy. That's the range of interventions termed as CPR in literature. When we look at mechanical ventilation is about trying to keep the patient breathing. So we talk about sustaining the respiratory function with a mechanical ventilator. Then we have artificial hydration and nutrition. Remember in the previous slides, we talked about culture, we talked about religion. So in some cultures and in some areas, it is considered that if we put a put the patient on parenteral nutrition, it is considered to be a life-prolonging intervention. Now, when we are doing advanced care planning, we do it within our cultural setup. So it's now in a Kenyan context, so that we are able to give patients the care that they need, the care that they deserve, and we are able to respect their autonomy in making decisions about their care, and we are able to involve the patient and their families in making decisions. Now, we talked about a medical agent. Some of their responsibilities include making choices about medical care, reviewing and releasing medical records to the healthcare providers, arranging for the care and treatment, and making decisions on situations. So it could be at home, how the patient's things are going to run while the patient is in hospital, and decide which kind of care and who is going to provide that care. Am I going to bring the patient to Kenyatta? Am I going to take the patient to Kiambu district? Am I taking them to Aga Khan? And what kind of care is the patient going to be given? So the patient is the person who needs to nominate a medical proxy. So let's not assume that anyone who has been documented as the next of kin is the one who has the right to make decisions for the patient. Good practice should be the patient should be the one to direct us who is their medical proxy. So they consider the following things. They choose a person who can make difficult decisions under pressure or in an emotional situation, a person who understands what the preferences, the values, and the goals of the patient is, and a person who can actually be trusted. Because sometimes you might choose a relative to make decisions for you, but when they're told that your lungs are failing, they might ask, what is the point of keeping you alive? And some of them might be making calculations of how much they are going to inherit after you pass away. So they might not be the best people to make decisions for you. So it should purely be guided by the patient. So the 5 things we look at when we are talking about advanced care planning is having a medical proxy. Who is the person making decisions? Number 2, does the patient wish to have life-sustaining therapies or not? In most advanced directives, if you look at it, you'll find a list of diseases. So you'll find there's metastatic cancer, there's organ failure, there's brain death. So you'll find that it has named conditions or situations that actually will put a patient in persistent vegetative state or with a poor quality of life. But when the patient is able to recover by us intervening aggressively, then it is also have the place of care. Does the patient want to be home, in hospital, in a hospice, and what kind of care do they want? Then there's the spiritual or social care and any other wishes that the patient might want to express. So now I want us to understand how advanced care planning has come to be a concept, or why it's even important for us to talk about it. Now, mechanical ventilation and CPR became a part of medical practice between 1930 and 1950s. And in this era, the focus was on sustaining the life of a patient. Physicians were the ones making decisions. The doctor was the one deciding. And if you've met people who were born in that era, even as patients, whenever you ask them what they think about their illness, about their treatment, the response usually comes, the doctor will decide, the doctor knows best. But in 1960, an attorney in Illinois, in America, developed the concept of living wills, that patients had a right to make decisions, especially about life-sustaining therapies. And the focus at this time was on patients who were having terminal or life-limiting illnesses. It was to sort of save the patients from their life being sustained indefinitely when the outcome is want that intervention. In that era also, death was considered to be a 1960, the concept of living will started to be a discussion that patients should decide, if I have a terminal illness, do I want people to
Dr. Nafula?
Yes.
Sorry, Doc, you're really breaking.
I'm really breaking. Let me try and sorry. Let me try and reconnect to the internet. Give me 1 minute.
Okay. As she's trying to reconnect, we wish that you put your questions on the Q&A so that we are able to respond to them. And any other questions you have around advanced care planning, we hope to be able to answer your questions satisfactorily. So please interact with us and we'll be able to answer your questions. Thank
you.
Okay,
I've logged into another network. Let us see if this will be better. Am I still breaking? Okay.
No, you're audible. Thank you.
Okay, I'll go back to the previous slide because we're talking about history of advanced care planning. So in the era of 1950s, 1930 to 1950s, CPR and mechanical ventilation became part of medical practice. And it was very important that patients are kept alive. So the focus was on sustaining life and decisions were made by the physicians. So death at that time was considered to be a medical failure and patients really had to be kept alive at all costs. Now in 1960s, an attorney in Illinois developed the concept of living wills. And the focus was really on patients with terminal illnesses or life-limiting illnesses to actually allow the patient to make a decision whether they wanted to be kept alive or whether they wanted to accept that they have a terminal condition and they would die naturally. So fast forward to 1975, the young girl in this picture is called Karen Quinlan. Karen Quinlan grew up in New York, then moved to New Jersey in 1975. She was 21 years old. After moving from home to New Jersey, she moved from home. 2 days after moving from her parents' house, she decides to go for a party. Now, Karen was on a diet. She had not eaten for 2 days because she was trying to lose weight to fit into a dress that she had bought. So she goes to a party, she has not fed, she decides to take a lot of gin and tonic. This is a true record from the reports that are in research. So she takes a lot of gin and tonic and Valium and other drugs and gets intoxicated, suffers a cardiac arrest. She's taken to an emergency room in New Jersey. She's resuscitated successfully. Then she remains in persistent vegetative state. 1 year down the line, her parents decide if her medical condition is not going to improve, they need to withdraw her from life support. So, of course, ethically, medical practice, you cannot withdraw a patient from life support. So the parents go to court wishing to withdraw life support. So the court grants the parents their wishes to withdraw life support, because they say if the patient's condition is unlikely to improve, what is the point of keeping her on life support? So the life support was withdrawn in 1976, but Karen lived until 1985 and she died. Now, after that case in 1976, California passed the Natural Death Act. So the Natural Death Act gave patients the right to decide whether they wanted life-sustaining therapies or not, whether they wanted to be on life support or not. So the law says at that time that if a patient had an advance directive, the wishes of the patient had to be respected. Then in 1977, the state of Arkansas passed an advance directive legislation that any patient who had an advance directive, their wishes had to be respected, and their medical care would be given as per their wishes. In 1983, the state of Pennsylvania now enacted a durable power of attorney. So yes, you have an advance directive. So who is going to make decisions for you? That also was made legal in America, that you had to appoint somebody. Not only was it important to document your wishes, but to also appoint somebody to make decisions for you. Now, in the same 1983, Nancy Cruzan is driving home from work. She was working in a cheese factory. She gets a road accident, her car flips, she's thrown into a ditch outside the car. She suffers very massive injuries. She was 25 years. Again, presents to an emergency room. She's resuscitated successfully. She remains in persistent vegetative state. Now, remember, at this point in time in America, there was a law saying that you had an advance directive, you had a medical proxy, and we needed to respect it. So when the parents went to court to petition that the life support needs to be withdrawn, the courts ruled that, first of all, those were not Nancy's wishes, and she had not appointed her parents to be her medical proxies. So a series of court cases followed for 7 years, and finally a Supreme Court authorized withdrawal of life support in 1990, and Nancy died 1 month later. Now, that 1990, America became the first country to have legislation on advanced care planning. So they have what is called the Patient Self-Determination Act of 1990, that of course has since been amended. So in this act, it was mandated that any patient presenting to hospital needed to be provided with written information, first concerning their right to make decisions and to make an advance directive. Also, it was mandatory to document in the patient's medical records whether they had an advance directive, and care was to be provided to anyone presenting to hospital with or without an advance directive. And hospitals had a mandate to educate their staff and the community on matters of advance directives and advanced care planning. So as we speak now, countries that have advanced care planning legislation, in the UK, they have the Mental Capacity Act that came up in 2005. Canada, Australia, and a few other European countries have legislation on advanced care planning. Now, when we come to Africa Africa is a resource-limited setting. Access to life-sustaining therapies, the ventilation, CPR, all these things we're talking about is almost impossible in many areas, including even our own country. There's very poor access to life-sustaining therapies. Advanced care planning remains a foreign topic that is rarely discussed. There's little research in the area, especially in Africa. There is no legislation anywhere in Africa on advanced care planning. Even in Kenya, as we speak, advanced care planning remains a hospital process. It is guided by hospital policies, and most of our hospitals, this is non-existent. Some hospitals have advanced directives or a DNR form, but from even what we are discussing, that is not adequate. Advanced care planning is about a process. It is not about signing a form. It's about a process of understanding what the patient wishes to have as their care, involving the patient in decision-making. So then we ask, what are the barriers to advanced care planning? First, there's a lack of knowledge and skills on advanced care planning. It is a topic that is not taught. At least I do not recall learning it in medical school. I learned it at master's level. So the knowledge and skills of how to initiate these discussions, or even what the process is about, even the form, if we have an advanced directive, many healthcare providers do not know what that is, how to use it, what the law says, we have no idea. Then communication skills, also some healthcare providers lack communication skills. Therefore, it's again a hard task to initiate a discussion. Then there's a debate of who should start that conversation. Should it be the nurse who is triaging the patient? Should it be the nurse taking care of the patient in the ward? Should it be the primary doctor seeing the patient? Should it be the palliative care specialist? Or should it be the specialist who is providing care for whatever diagnosis the patient has? And again, when should this discussion start? If we refer back to the Self-Determination Act of America, they said that everyone presenting to hospital, it was the hospital's mandate to initiate these discussions, not just with their patients, but also with the community, for people to become aware that there's actually a process like that I have a right to make decisions. And this is the process of how I can make decisions about my healthcare when I still am sound of mind. Then we have our cultures. We cannot ignore culture, especially when we're talking about advanced care planning, because advanced care planning means we have to talk about the hard topic of death and dying. So in many cultures, talking about death is a taboo. So even in the countries that I have mentioned that have laws and legislation of advanced care planning, discussing about it is still not easy, because you literally have to talk about options of treatment. You have to talk about worst case scenarios. Nobody wants to hear that they're dying. Now, when we look at our cultures, European cultures are autonomous. People make decisions for themselves. Mexicans, Asians, Africans, research has shown that our cultures are family oriented. So decision making, especially when there's a critical illness, when there's a life-threatening or life-limiting illness, is done in a family kind of setup. It is not me to decide. It is me to consult my brothers, my husband, my sister, my father. Then we come up with a decision. So we have to understand these cultures when we are trying to have a decision made. And it's important to also just explore with the patient, what kind of culture, what kind of beliefs does the patient have? Because religion has also come, education has come, and our cultures have really changed over time. Then we have the involvement of family. Sometimes it can be a good thing, sometimes it can be a barrier. We have patients who have explicitly said they do not want life-sustaining therapies when they're incapacitated, but we find them in ICU because their family has decided that decision was not made soundly. So we've had patients who decline treatment and their families still feel they should try everything that they can. So we have to understand all this. So right now, when we look at advanced care planning, how it has evolved over the years, it is very good to have an advanced directive. And the reason is because an advanced directive, where there is legislation, it is a legal document. It will protect you as a physician. It will protect your patient. It will protect the kind of decision you've made about the care of the patient. Now, when we look at Kenya, there is no law on advanced care planning. There is no law on advanced directives. Those, in fact, if you go to court, they'll tell you they are merely hospital documents. So we get ourselves in a lot of ethical dilemmas, especially where the family or the healthcare provider does not agree with what the wishes of the patients are. So yes, as much as we want to have documentation of living wills, we still need to rethink, because right now where the world is moving to, it is not about signing a form that I do not want to be resuscitated. It is about me having discussions with my family, with my healthcare provider, for people to understand my medical decisions and agree that my wishes should be honored at the time when I'm incapacitated. So yes, we have the living wills. We want to know what the healthcare wishes are. Then the medical decisions, we know medical decisions are guided by our, we have a standard practice, we have guidelines. So our medical decisions also, as we are giving recommendations, are guided by that. Because our role as healthcare providers is to give recommendations to the patient, to the family, when we look at the overall picture of their diagnosis, their treatment, their prognosis, their outcome, and to empower our patients to be involved in the decision-making, and also to empower the patients to appoint a healthcare power of attorney. Now, whenever we discuss this issue, the issue of financial wills will come up. This is about healthcare. It is not about when I die, who is inheriting the money in my bank account or the car that I'm driving. This is about when I'm incapacitated and cannot decide what kind of medical care to have, who is going to make that decision for me. And that should come out clearly when we are having these discussions. So as I end my presentation, it is a series of discussions. It is not one discussion to just say, do not resuscitate, let's take a vent, let's do that. It is a series of discussions. Right now, we've been having a lot of family conferences running in the hospital as people are giving patients care, and that is part of advanced care planning. It is just that it is not formal on an advanced directive, but when you look at the content of the discussions that the healthcare teams in KNH are having with families, actually it's advanced care planning. So my hope is that in future in Kenya, we'll have legislation so that the process can also be smooth, especially where there's conflict about what the patient wants, what the family wants, what the healthcare provider wants. Some situations are clear-cut and some are not. Thank you for your attention.
Thank you, Dr. Nafula, for that a good presentation. There are very many questions on our Q&A. Please continue putting your questions there. We will have Dr. Nafula and our next speaker answer your questions after she has presented. And our next speaker is Erin Das. Welcome, Erin, to speak to this audience. Erin is a registered nurse from Canada. She's specialized in pain and palliative care. She has worked in different parts of the world, including Canada, USA, Bangladesh, and she has some wealth of knowledge on management of patients in end of life. And also she has experience in issues of advanced care planning. She's an advisor to the palliative care team at Kijabe Mission Hospital. Also doubles up as a therapist with Faraja Cancer Support Trust. She's a nurse mentor and a faculty member of KEPCA, Palliative Care Nurse Leader Program. So welcome, Erin, and speak to us. We wait to listen to you. The audience will put their questions on the Q&A. Very many questions. Dr. Nafula, please don't go away. Stay on. Thank you.
Yes, I'm still here until the end of the session. Yes.
Thank you for the introduction. It's a real honor and pleasure to be here today. Again, my name is Erin, and I want to continue the conversation on advanced care planning by giving you, as healthcare workers, some tips on how to communicate. I think it's really important that Dr. Esther Nafula set the stage for us on all the information on what is advanced care planning. And I hope in the second part of this session, we can review some of the things that you can begin to put into practice in small ways to incorporate advanced care planning into your work. So this afternoon, I hope first we can identify how to communicate with patients and families related to advanced care planning. Then we're going to shift into 5 useful tips to incorporate into your practice to ensure that you are good at communicating this type of care and planning. And then we'll finish with some of those international best practices that Dr. Nafula was talking about in countries where it is legislation for advanced care planning and advanced directives to be happening. And how can we begin to brainstorm and come up with ideas and how we can adapt this to our context here in Kenya. So I want you to think of a situation where you are in an office or in your practice at the hospital where you are face to face with a patient. Oftentimes we end up seeing patients with their family members, which is great, especially when it comes to advanced care planning. But I want to set the stage and I want you to think about a time recently in the near recent past that you have been with a patient and a family, and you've begun talking a little bit about what they are hoping for the future for their health. So when we think about how to communicate related to advanced care planning, the first thing we can do with some of the patients that we see, depending on where you're working, maybe it's the emergency department, maybe it's in an outpatient clinic, or it could be on the wards. A really important way to begin this type of communication of advanced care planning is to arrange a family meeting. It's really important when we talk about serious discussions, such as what Dr. Nafula was saying, where we ask for people's wishes, we want to know more details about their plans, if they would like to be on life-sustaining support or not. These kinds of discussions are not so easy to have just in the hallway or at the bedside even. It's really important that we prioritize and arrange a family meeting, because this is what often works best for patients and families. You do want to make sure the right people are at the meeting. As Dr. Nafula said, sometimes family dynamics are interesting and we find ourselves having many people wanting a say. So I think it's really important that we identify who are the people that need to be at the meeting and make sure that they're available, and we schedule the meeting where all of those people are able to be there. You want to make sure you have privacy. If we are expecting a patient or a family member to make official decisions on behalf of their loved one, it's really important we have privacy. You don't want to be expecting someone to make decisions when many people are listening to them, or the neighbor in the next bed is also overhearing. It's not the best time for people to make those types of decisions. It's important that we also involve other healthcare professionals. So that could include people on your ward, such as the nurse, possibly the charge nurse, or someone who knows the situation well. It could be the primary physician would be at that meeting. Someone, if your unit or your department has a social worker or any other allied health professional that you think would be helpful to have at that meeting. Oftentimes when we talk about advanced care planning, we're looking at the big picture. So involving as many people that have been involved in the patient's care as possible is really important. As the person that could be heading up the meeting, it's important that you identify before the meeting occurs, what do you want to communicate and what do you want to achieve? Many times we find ourselves in family meetings or these types of situations, and they can go for a very long time because we might not have actually identified what do we want as an outcome of this meeting. So when we think of advanced care planning, there's so many things that Dr. Nafula was saying that we'd like to achieve or we'd like to think about, and probably you won't be able to do that all in one meeting. So when you begin the journey with a patient and a family to try to help them make decisions and to make things more official based on your hospital policy, I think it's really important that you identify what's important for this specific meeting. You may want the first meeting to be when you decide on who the medical proxy is. So making sure that everyone who's at the family meeting knows that that's what is going to be communicated today. And then once you achieve that, it's okay to stop the family meeting. You can arrange for another meeting. Maybe you also would like to identify what are the patient's wishes, but they may never have thought about that before. So you might give them some things to think about before you have your next meeting. It's really important that you identify what you want to achieve during that time. So as we go back to our patient situation, this is what oftentimes we end up seeing. We see patients that are waiting. This is I believe at KNH in one of your wards where people are waiting for cancer treatment. And I think sometimes we often feel the pressure to make immediate decisions as things are happening in a crisis. As Dr. Nafula said, sometimes there's been a car accident or a stroke or something very serious where decisions need to be made. But we also have patients that are going through life-threatening or life-limiting illnesses such as cancer. And they may be patients we see on a regular basis, and we may never have thought to talk to them about what their wishes are. These are the types of patients that we can hopefully work together with over a longer period of time to help them come up with good ways of identifying what do they want. Patients that could fit into this category would be our cancer patients, anyone with a cardiac disease, diabetes, anyone with a non-communicable disease. Again, are definitely candidates for having these types of discussions. In general, in many countries, as we talked about before, advanced care planning is for everyone. We talk about advanced care planning for people that are not sick, because in the event that you are in a car accident, if you were able to make your wishes known prior to that, your family then would know how to make decisions on your behalf. Oftentimes in the medical centers that we work in, our patients are ill though. So oftentimes we find ourselves in situations where we're helping patients and families make decisions for someone that is unwell. So we're now going to shift into the useful tips. So hopefully at the end of today's session, you will be able to take away at least one or two things that you will begin to incorporate into your practice as you communicate and interact with patients and families. So this is a set of useful tips that was adapted from a guide that was created in 2017 in the USA. Called the Serious Illness Conversation Guide. And what this guide does is it helps clinicians, including nurses and doctors and other healthcare professionals, to help patients and families when they have a serious illness. It is useful tips on how to communicate and how to set up those discussions, and really how to get good information from our patients so that we feel that we are all on the same page. The patient feels heard, and the clinician is more informed as how to best care for the patient and family. So the first tip that I'd like to go over, and with each tip I will give you an example of how you can say this. The examples that they have shared in this guide are research tested. They have tried these words, these specific words out with many different patients, and it's been really positive. So the first thing we need to do is we need to set up the conversation. So this is a bit similar to what I was talking about with the family meeting. We need to introduce the purpose of why we are getting together. This conversation also helps us prepare for future decisions. So it could be a situation where you have a patient who's been coming to the clinic for quite some time, but seems to be deteriorating. So the clinician maybe is clued in that the patient is deteriorating. They're having to come in every week now for follow-up visits, and their symptoms are difficult to manage. maybe in the near future, some decisions would need to be made about how best to care for this patient. At the beginning of the conversation, we also really need to make sure we ask permission of the patient and the family to continue with a difficult conversation like this. So we don't want to assume that all patients are ready to have conversations about advanced care planning. We do need to ask for their permission. So an example of how we could do this is as follows. I'd like to talk with you about what is ahead for your illness and do some thinking in advance about what is important to you so that I can make sure we provide the care that you want. Is that okay? So as you set up the conversation and as you ask for permission, it allows us to move into the next stage of this discussion. And of course, you, just as I, when I face many patients and families, there might be situations where the patient is not ready to go forward. Maybe they're quite emotional today, or they really are just not feeling well, they're nauseated and in pain. If it's not okay for them to talk about what's ahead with their illness, then you do need to stop. And you do need to ask, maybe we can meet again this afternoon once you're feeling better, or possibly we need to meet at another time in the week. So you do need to respect what the patient is saying. If they're not interested in talking about this, then we do need to find a better time or another time. The second tip is that we then begin to assess our patient's understanding as well as their preference. So we do this by asking very simple and very straightforward questions. So what is your understanding now of where you are with your illness? So this is pretty common for us to be able to understand, what does the patient know about their illness? Again, as Dr. Nafula was saying, our cultures and sometimes our religious preferences or our family preferences, sometimes patients don't fully know what's happening with their illness. Sometimes they know a little bit, sometimes they don't know much at all, and sometimes they do know a lot. And that's okay. What we're trying to ask from this question is what do they understand what's happening right now? And this can be a question that's asked to the patient as well as the family. It can be an open question. It is really important that we allow our patients to talk and to share with us. And this next question, I really appreciate, and I think it's really helpful in our context in Kenya, where sometimes you have families that maybe prefer not for their loved one to maybe know fully what's going on, or they want to spare their loved one from some of the emotional toil of fully knowing their diagnosis. This question I really appreciate because it goes back to the patient and it allows the patient to decide in a culturally contextual way what is appropriate and what is their preference. Because I think at the end of the day, all individuals should have the ability to decide how much information they want to know. They don't need to know it all. Nobody is forcing them to know information about their illness, but this gives the patient some autonomy to make that decision, and for us all to know, the healthcare professionals as well as their family, to know what they're interested in. So the second question is, how much information about what is likely ahead with your illness would you like from me? So for some patients, they don't really want to know. They would rather their spouse, or possibly in this situation, maybe a medical proxy or someone who's going to make decisions for them. They would like them to know that information. But this is a very easy way for us to ask information from the patient so that they are the ones who do make the decision. And again, once we know this information, we can move forward and we can decide how much information to share and what do they fully know. And then again, who do we share that information with? So I think these are really, really helpful questions, especially given our context, and some family dynamics may be different than others. The third tip is the area that I often find in our clinical work, which can be very, very difficult. And this is when we begin to share the prognosis with our patients. So some things to remember, it's really important that we are honest and we are truthful about their prognosis. We have some ways to frame it that will help clinicians to do this in a way that's not rude or that's not mean. And we can use a phrase wish or worry and hope and worry statements. And I'll give you an example of how we can do that. It's really important as we begin to share the prognosis or a change in status of our patients, we allow for times of silence, and we also explore emotions that our patients and families may be experiencing during that time. So here's an example. I want to share with you now my understanding of where things are with your illness. And then you would go on to explain what's going on with their cancer, or maybe with their heart failure, or possibly their COPD. It can be difficult to predict what will happen with your illness. By saying that, you're just showing the patient and the family that we're all human, that giving a prognosis can be very difficult from the medical perspective. And we then would move on to say, I hope you will continue to live for a long time. I think it's very true as medical professionals, we want our patients to live well. We want them to be doing well. We don't want them to have many symptoms. But in reality, I'm worried that you could get sick quickly. And I think it's important we prepare for that possibility. So when you say it like this, when you say, I hope for you to continue to live well, but I'm worried that you could get sick, I think it's a very sensitive way, and it's an empathetic way to tell someone the situation, and that we need to think about, and we need to possibly begin to plan for a future that isn't exactly as the way we were hoping it would. You could also say, I hope this was not the case. I hope it was not the case that your cancer is spreading, or that your cancer has metastasized to your brain. But I'm worried that this may be as strong as you will feel, and things are likely to get more difficult. When you talk in this way, when you communicate in this way, when we think about advanced care planning, we are being very honest and we are being very truthful about their situation. We share that we don't exactly know what's happening, but we know that things are changing and that we are worried that patients may not fully recover from what's going on. Again, this moment of communication is going to be really difficult for patients and even for clinicians. So we need to be sensitive to people's emotions during this time. So as we share the new update on their health status or the current situation of what's going on for them, it's really important. The next step is to explore the key topics. And this is where we get more information about advanced care planning for our patients. We need to talk about what their goals are. What are their fears and worries? Do they have sources of strength that we could help encourage them with? Are there some critical abilities that seem to be difficult or lacking? Are there trade-offs? And how has the family been informed, or how is the family involved in all that's going on? So I'll give you some examples of how we can say this. So when we talk about advanced care planning, we want to know what the wishes are of our patients. So one thing you could say is, what are your most important goals if your health situation worsens? So what's really important? Maybe there's someone in their family that's getting married soon, or they were really hoping to go on a holiday. They'd really like to return to their shamba. There might be something that's in the back of their mind that is a goal that they've been thinking about. And it's really important for us to know, as someone declines or deteriorates, what is the most important thing for them. On the other side of that, it's important that we also understand and we ask them, what are your biggest fears and worries about the future with your health? This might help us identify areas that we can support the patient and the family. Maybe there's something they're very worried about. Maybe they're very worried that one day they'll never be able to walk again. Maybe they're very worried that the pain will be so difficult and they might run out of finances so they can no longer pay for their treatment. These are really important as we think about and we help them plan for the future. I like the next one. It says, what gives you strength as you think about the future with your illness? There will be areas in every patient's life and family's life that will give them strength. What are those things and how can we encourage and support them? Even during a very difficult time, there will be areas of strength that they can think of. And we want to really empower them in these areas. Maybe they really enjoy singing, and maybe even being bedridden and being confined to their home, they can still sing as people come around them and draw around them. And this is really important as we think about the future and we help them plan for what's important for them during this time. The next one is, what abilities are so critical to your life that you can't imagine living without them? This helps us a little bit understand sometimes how much life-sustaining support a patient and family would appreciate. So for some people, the ability to talk and the ability to eat on their own and the ability to walk independently are so critical to them that they couldn't imagine living their life without them. Their quality of life would be so poor that they wouldn't want to continue in that situation. So those kinds of things are really important for them to begin to think about things like life-sustaining support. So these are really helpful questions to help us understand and help them understand what's important to them. Again, if you become sicker, how much are you willing to go through for the possibility of gaining more time? This might help us identify if they are interested in things like CPR. Would a patient be interested and would they be willing to spend more time in the hospital at gaining more time? Or maybe they're at a point in their illness and the trajectory of their illness that they are okay if they are not resuscitated. They don't, they feel at peace and at ease with a do not resuscitate order. And the last one is, how much does your family know about your priorities and wishes? Again, most of the time, these meetings will happen with our families in our context here in Kenya. Many times we have meetings where many family members are involved. Again, but there are situations where maybe you don't know how much the family is aware. And this helps with the idea of the medical proxy. Does the person know what your wishes are? And do they know where your priorities are? And the final one is to close the conversation. So it's really important as we think about these types of conversations that we're having with our patients that we summarize what has happened. It is a very emotional and very difficult conversation to have. So as the clinician, it's important that you begin to summarize at the end. You do need to make a recommendation. Patients and families look to healthcare professionals and they trust us. So it's important that we make a recommendation at this point as we prepare to close the meeting, and we check in with the patient. We do, again, at the end, when the meeting is nearly over, we need to affirm our commitment to continuing to support them, regardless of what their decisions are. When we have an advanced care plan, we cannot judge our patients and families if it is something that's different than what we agree with. We still need to affirm our commitment to care and support for these patients. So the example is that I have heard that, I heard you say that, and then maybe, for example, their wish is to have a do not resuscitate order. They would appreciate some planning ahead with a trip, and they really would like to have some of their pain managed well. And that's really important to you as a patient. So the clinician continues, keeping in mind with that and what we know about your illness, I recommend that for example, if someone has said that they would like a do not resuscitate order, you could say, I recommend that today we sign our hospital policy that allows you to have a do not resuscitate order. I recommend that we put it in your chart and that everyone in your family is aware of what your wishes are. I do recommend that we consult with the pain specialist and we get your pain managed. And hopefully as a family, we can all find a way to support you with the final trip that you'd like to make. This will help us make sure that your treatment plan reflects what's important to you. So you do need to give a recommendation. If you feel like the patient and the family have made a decision, it's really good to summarize and make that recommendation. And then you say, how does this plan seem to you? You allow the patient to confirm what you have said and agree in that situation. And it's very important at the end that you say, I will do everything I can to help you through this. So you affirm the commitment that you have, that you are their clinician, that you're there to support them. This can really help, this guide can really help us as we engage in advanced care planning conversations and as we support our patients living with serious illnesses. As you finish your conversation, it's very important that you document as well as communicate with any key clinician. So there may be that some people weren't able to attend your meeting, but if something as serious as a do not resuscitate order has been decided, it's really important that you discuss that with the other team members so everyone is on the same page. So this is an example of what the Serious Illness Conversation Guide is. We have been using it a bit at Kijabe, which has been great. And we actually bring the form with us, so we don't forget what to say. And it has been useful in how we communicate with our loved ones when they're, with our patients and families when there is a change or when there has been a serious illness that we need to discuss and plan ahead for. So at the end of the meeting today or the discussion today, I've included resources so you can follow up if you'd like to print out. This is a PDF. If you'd like to print it out and start using it, that could be really helpful. So again, as we think of our patients and families, it's so important as we partner with them and as we work with them. Here is a lady who's been going through breast cancer treatment, and she has been needing some support as she thinks about her future. So here you can see her husband is with her. In this situation, it's most likely that he is her medical power of attorney or medical proxy. And this would be a really good patient and situation to begin having conversations like this. So I just want to take a minute. I know that we're getting closer to the end of our session today, but I just want to take a quick minute. If you guys can put in the chat, what is one tip or an example that you think you could start to use in your practice this week? So we've been talking a lot today about advanced care planning and different things that you could begin to incorporate. We did talk a lot about the fact that currently in Kenya, it's not a legal document. But depending on which hospital that you work at and the different policies that are in place, yeah, I'm hoping there are a few things that you can begin to use in your practice. So if you wanted to put in the chat, I know you guys were on the chat earlier. If you wanted to put in the chat an example or a tip that you would be you'd like to commit to practice this week, that would be great. And then we can just, after the session is over, we can look at some of those things that you are interested in doing. So in terms of international best practice, and then we'll end with this now, globally, there's a variety of current best practices, most of which are, of course, supported through the legal system. So that's what Dr. Napula was talking about, the advanced directives, the power of attorney, the do not resuscitate orders. In Kenya, so those are globally what generally happens. Along with the legal support, there's been a lot of practical advocacy campaigns and things that families and patients can do to plan for their wishes. So I'll give you a few examples. At the end, again, of this presentation, I've included some resources. So if you wanted to look more into them, you are more than welcome. So we were talking earlier about the 5 wishes. This is a tool that's geared at helping people talk about their wishes if there might come to a time when they cannot share them on their own. So if they're incapacitated and they're not able to explain to the healthcare professionals what their wishes are, this is a tool that you can use to help the patient and family identify what those wishes are. There's a campaign in Canada called Speak Up, and this includes advanced care planning as well as goals of care discussions and the substitute decision maker or the medical proxy. So this again is a toolkit that can be used to help patients and families identify how to plan ahead. And the last one, which will take a little bit more time to explain, is the 5 simple steps. This is used in the UK. And these are steps that patients and families can take to record and share their plan with their loved ones. So the advanced care planning, or the 5 simple steps, are number 1, to think. Think about the future. Think about what's important to you, what you want to happen or what you don't want to happen if you become unwell. The second one is talk with your families and friends and ask someone to be your spokesperson or your proxy, the power of attorney, who could speak if you're no longer able to speak for yourself. Number 3 is record. Write down your thoughts about your own advanced care plan, including your spokesperson and where you're going to keep that record, so that your medical power of attorney knows where your record is. Number 4 is discuss your plans with your doctors, your nurses, your carers, whoever might need to help you in the time of need. So maybe you are a regular patient or your patient is regular at KNH. Maybe this would be important to have on their file, their medical file. And the final one is share this information with those who need to know about it. So again, if you have a regular doctor you go to see or something along those lines, it's important that those who may need to help you in case of emergency know where that information is. So in Kenya, currently our advanced care planning is dependent on our hospitals and our policies in place. It's not a global or national, sorry, it's not a national policy. But I did want to end the session today with a few comments from Dr. Weru. In 2017, he was interviewed for a news article on advanced care planning and palliative care. And he has some really inspiring words and comments. So I'll end with this today. For most people in Africa, discussing death is considered a taboo. Talking about advanced care planning is therefore seen as a foreign concept. But it should be seen as part of palliative care, the holistic approach to care for families facing any life-limiting illness. By planning in advance, people can have a timely discussion about how symptoms might be managed, as well as how supportive care will be provided. I can't see. From the medical professional's point of view, a plan offers guidance on when end-of-life care discussions should be initiated and provides suggestions on the categories of patients that should be considered for a talk on appropriate end-of-life care. Education across the board is key to improving the acceptance of advanced directives, which is what we're doing today here. This can be driven by clinicians, patients, and their families. But healthcare workers need to approach the topic without attracting cultural and societal conflict. Patients and families need to be told about the importance of reducing family distress and conflict. In particular, patients with advanced illnesses such as heart, kidney, dementia, and liver disease need to consider planning ahead, as the trajectory of these diseases is similar to cancer through the timeline, though the timelines differ. One common misconception that needs to be addressed is that filling in the advanced directive means giving up on a patient's recovery. It should instead be seen as a patient's right. Communication skills, particularly among healthcare workers, are critical when initiating any discussions on this issue. And finally, we should encourage more physicians to patient discussions in Kenya. So this was many thanks to Dr. Weru, who wrote an article in 2017 and was published online. I think this was just an encouragement to each and every one of you that although these discussions are difficult and very hard and challenging at times, it is what we are to do. And I think this is the way that we can really encourage our patients. It is not us giving up, it is allowing us to support our patients and should be seen again as the patient's right. So my references are here, the different tools that we use today, just a few examples, and then the article. So thank you very much.
Thank you, Erin, for that very well researched presentation. And thank you for talking about communication, which is quite a difficult aspect of our care for many of us as healthcare workers. It's not easy to speak about end of life issues, to speak about what I would want when I am about to die. It's not easy, but I think those tips have come in handy. We have several questions here, and some of them have already been answered on the chat, but then Dr. Nafula, there's a question here on how do you handle relatives of patients who claim the patient has a standing DNR, do not resuscitate order, but do not produce. Oh, you can't hear me. And now? Hello? Hello? Can you hear me now?
I can hear you, but maybe it's not.
Oh, okay. The question is for you, Dr. Nafula.
Yes.
The issue of living will, written or spoken. Is someone who is asking, relatives come?
Yes, I didn't hear the question, please.
Your network is having issues.
Yeah, my network is a bit bad. Yeah, which question is it? Sorry.
Oh, okay, it's the question about relatives talking about a DNR on behalf of our patient, and yes, and they do not produce any documentation. And then coupled with that, you can talk about euthanasia. Is it legal in Kenya?
Okay. Now with the DNR in Kenya currently, as we've said, it's a hospital document. So you might find the patient might have expressed a wish not to be resuscitated. So the best approach that we have in Kenya right now is actually to still discuss with the same family about what the wishes of the patient were, how that discussion of do not resuscitate came about, so that you can actually ascertain if it is the patient's wishes and give the recommendations again based on the condition of the patient, the prognosis, the diagnosis. So where DNRs are legal, that means where there is law about advanced care planning, the document has to be produced. Now in Kenya, if this document is not available, then it means you have to go through this discussion again, give recommendations, and come up with an agreement of whether the patient is being resuscitated or not. So as Erin mentioned, it is better if we start to have these discussions, especially with patients who have a diagnosis that is likely to become fatal or likely to have a poor prognosis. When the patient can still talk, we can have this discussion slowly for people to come to understand what their wishes are. In a time of crisis, of course, you have to handle it just as it is, it's a crisis. Now, euthanasia is illegal in Kenya. As far as the Kenyan law is concerned, euthanasia is murder. So if you agree to give a patient euthanasia, you'll go in for murder. It might end up being first degree or second degree murder. So Kenya, again, euthanasia is not legal, but we are going to do a topic on euthanasia because I've seen in the series of CMEs we've done from last year, the question of euthanasia keeps coming up. I think we need a session on what euthanasia is, and just what areas that have euthanasia, what the laws look like, and what it is in Kenya. But as far as we know, in Kenya, it is illegal.
Thank you, Doc. This other question will go to Erin. There's a question here. Someone has written a story about how a patient suddenly collapsed in the house and was taken to ICU. Tests were done, and including HIV test, turned out positive. The spouse signed do not resuscitate order. Following this order, she was discontinued from life support and taken to general ward. Somehow she got better and found a file over her bed, which the husband had signed. Her reaction was nasty. How does the doctor go around this ethical dilemma related to advanced life support? Before you answer that, Erin, this is also something to do with religious persuasions, where a family says that my patient or my brother, my son, prescribes or ascribes to this form of religion, and therefore we do not want them to receive this kind of treatment, or we do not want them to receive any, for example, blood transfusion. Erin, maybe you can unpack that for us. Thank you.
Yeah, I think this situation, it's very sad what happened. Obviously, the lady seemed quite sick. And I think it would definitely need multidisciplinary support. I think the family probably would need to go to some sort of counseling, because I think the trust that this woman now has in her husband must be broken. And I think it's important that we help facilitate good conversations, because I think it could lead to her not healing fully from her illness, and that she would have long-term psychological issues if we don't talk about this while she's with us. I think, of course, in this situation, it seemed like she was fairly well. So therefore, it would probably have been uncommon for her to have any sort of do not resuscitate decided upon. It sounded like she didn't even know she had HIV. So these types of situations are very difficult. I think as we go forward, finding out from patients and families who the best person is to make those decisions as a patient, or even for yourself, as you think about who you would want to make decisions for you. I think, again, it needs to be that trusting relationship. So it sounds like the relationship she may have had with her husband already could have been maybe a bit strained. So I don't think it would be a very easy ethical dilemma to resolve. And I think making sure that we have a psychologist or social worker to support the medical team in taking that forward. I think if the lady, Dr. Nakula could correct me if I'm wrong, if she was able to make decisions on her own, as in she recovered, she could possibly take that do not resuscitate order off of her file, because she would be able to make decisions for herself at that point. I believe medical proxies and power of attorneys for health only come into play when someone is incapacitated. So a lot of this information about who makes decisions for us, again, it's cultural. We know that many times, even if someone is able to make a decision, families don't often allow them to make a decision, which again, it's our cultural situation we find ourselves in here. But I believe from a legal point of view, a medical proxy doesn't have power over a patient if they are able to make decisions and if they're awake and alert. So again, in her situation where she said her reaction was nasty, it sounds like maybe she could look at her file and decide again if she would like to keep that do not resuscitate or have it dismissed.
Yeah, and I agree with Erin on that matter. And that's why we are talking about this, because when you're nominating a medical proxy, I'm sure even now as we are going through this discussion, there are some people in your family who you know cannot make decisions for you. and some who can make decisions for you. So it's actually very important for the patient to nominate somebody that they trust, and they will go by the decision of that person. So again, when we are having discussions of do not resuscitate, for example, my experience has been in Kenya, many families feel that if they choose not to resuscitate their patient, the family is going to blame them when this person dies. They're going to say, you're the one who let mom die, because if maybe she went to ICU, she would have survived. So people tend to keep off from actually committing to the do not resuscitate. And that's why you see, even from all these presentations, the emphasis is on the patient themselves, making their wishes known, and then the responsibility for the family and healthcare providers is to respect that wish, so that nobody will say, I am the one who decided my mother should not go to a ventilator. It is my mother who decided that she does not want to be ventilated. Back to you, Anne.
Thank you, Dr. Nafula. Thank you, Erin, for answering those questions very well. There is a question here, Dr. Nafula, that is asking you to clarify the difference between the person who makes health-related decisions and the asset administrator. I can see you've answered this, but I think you can say it loudly and of course expound on it more, because there is a conflict between, even when we ask for next of kin, people think we are asking for asset administrators. So
Yes.
maybe you can answer that. Yeah.
Okay, now, again, the emphasis on the role of a medical proxy. It is someone to make healthcare related decisions about treatment, decisions about the medical providers, decisions about resuscitation, and these decisions should reflect what the patient wants. So actually, if someone is going to be nominated as a medical proxy, it is important for them to know what the wishes of the patient are, so that they are able to respect it. Now, an asset administrator comes into play at the time when a patient has, okay, not even a patient, when someone has passed away and there's a will. Now we need to distribute the assets that the deceased person has left behind. So it is important when we are discussing with patients and empowering them, for them to know that the mandate this person is being given as a healthcare or medical proxy or power of attorney is not to go and distribute my assets or my wealth, but it's rather connected to my health. That when I am sick, I'm incapacitated, the doctors are wondering whether to resuscitate me, whether not to resuscitate me. I'm in persistent vegetative state, should I go on to a ventilator? Their role is actually to make those decisions when I cannot make the decisions.
Thank you, Dr. Nafula. Erin, what do you think about this question that someone is asking? Can we be asking for the medical proxy instead of next of kin in your perspective? What do you think? Because a lot of the times we ask for next of kin, and maybe someone has been brought in by a good Samaritan, and that ends up being in the records.
Yeah, I think
Erin?
it will take time in Kenya as we continue to raise awareness about these issues. I think using terms like medical proxy, we can begin to do that, but we don't have the legal backing at the moment for it. So it might be difficult for us to explain the full context of what it is. I think we can begin. I think we ask definitely who is your next of kin, and then we can right away after that ask, is there someone that you have decided who can make medical decisions for you if you're not able to? Again, it is really difficult when we don't have the legal backing of it. But if the hospital where you're working at does have a policy for that, and someone can identify someone as a medical proxy, that is really helpful. I see there's another message from Stella kind of along those same lines. So she is talking now about medical proxies when they might not align with the patient's view. What can you do if a medical proxy decides to do something that's different than what it seems like the patient has wished? And I think this can happen a lot. And that's why when we talk about the communication part of it, as patients and families, it's really important that we, as clinicians, remind them that they need to make sure whoever their medical proxy is knows what their wishes are, because at the end of the day, that medical proxy is going to be the person that's going to make those decisions for them. So as a patient, if you haven't made very clear what your wishes are, it's going to be very difficult for that person to make a decision for you, and they will just make it based on what their, what their ideas are. So in those situations, you might have a medical proxy that may not align with the wishes of the patient, but they are the person that has been chosen to make the decisions for them. So it can get a bit confusing, and hopefully in the near future, Kenya is able to rally, especially with our national policy on palliative care. We can come together and find ways that we can support patients and families, especially in a legal way. I think that could really help us make this clear.
Thank you, Erin. This one is for you, Dr. Nafula. Have we started any discussions on issues of advanced care planning to be entrenched in our legal documents? And if yes, how far are we? The other question would be from me, from the ethics point of view. The national government has started thinking about ethics in all hospitals. Do you think this will be the starting point of demystifying the issue of discussing end-of-life issues or difficult decision-making where health is concerned? Health-related decisions and difficult ones are concerned.
Okay, thank you for the questions. Now, so far, we do not have anything formal yet on legislation for advanced care planning. And I think it is something that we really need to look at. The discussions are happening, even like what we are having now. And we really need to look at it from a Kenyan scenario. Actually, what kind of legislation do we need? What kind of support do our patients need? And what kind of advanced care planning would actually work for us? Now, again, from when we are looking at ethics and discussing end of life, I think advanced care planning is a good avenue to have those discussions. I've seen someone type a question, a comment that the decision to resuscitate should be left to the clinician. Now, our role as healthcare providers should be to recommend the treatment. The decision to be resuscitated or not actually should lie on the patient, because it is common even within our ICUs, we'll go and find patients with a poor prognosis on mechanical ventilation, and patients with a good prognosis are being denied the ventilation because, we have limited resources. So really the decision to resuscitate, clinically we will give a recommendation, but the ideal situation should be before someone has a chronic illness or someone arrives in a crisis, their family should be aware what should be done. And as I say, these things happen even in Kenya. You will meet some families who will tell you, my mother has been sick with cancer, she's now having organ failure. She said she does not want to be admitted in hospital and we would wish to honor her wishes. So what kind of care would you support us to give our mother? So the emphasis again should be on people understanding the range of interventions that exist, and then the practical bit. Because as clinicians, sometimes you get patients who are brain dead, for example. You will recommend that this person should not be on ventilation, should not be resuscitated, but you still find the family is not understanding. And it is because we are having this discussion in the middle of a crisis. So going forward, Anne, I think as we are thinking about ethical practice, having ethical committees within hospitals, advanced care planning should be part of these plans so that we can empower people to have these discussions early before a crisis, when they're still fine, when they do not have a chronic or a terminal illness. And also something that needs to be noted is that an advance directive, just like the other will that we write with a lawyer, the date of the advance directive, we use the most current one. So people can revoke an advance directive. I can say I do not want to be resuscitated and tomorrow I can change my mind. It should be okay. So the discussions are, that's why we are emphasizing that it has to be a discussion. It's ongoing. We look at the factors. A patient with cancer could still get a heart attack. A patient with cancer could still get a stroke. So what does that mean? Should they not be resuscitated because they say they don't want to be resuscitated for cancer? So the discussions have to be ongoing and the forms have to be updated as needed. Some facilities in Kenya update their forms every 2 weeks. Some update the forms every time the patient comes to hospital, and some update the form whenever the patient's situation changes. So it's a flexible process, really. Even globally, it is a flexible process. It involves discussions and just making decisions, informed decisions based on the condition of the patient or the changes that are happening.
Thank you, Dr. Nafula. I think we have answered most of the questions that have been asked, and there is great reactions here that this is very informative. Thank you very much, Erin and Dr. Nafula, for providing your knowledge to us and sharing very well. Of course, these webinars are recorded and they are uploaded on our website on KNH, so you can always access them on the website. Thank you very much for the participants and listeners for finding time to be with us. Those who are prescribed to whatever association, you have information there on how to get your CPDs. And I think without much ado, we end our session here unless there is a reaction from the presenters. Erin, would you like to say your parting shot?
Thanks for your time, everyone, today. Yeah, if you are so inclined, do think about your own personal advanced care plan, and then from all the tips and things we've shared today, think about how you can incorporate it into your practice for your patients. Good luck.
Thank you. Dr. Nafula, your parting shot?
Yes, for me, I would like to say thank you for finding time to come and listen to this great topic. And I would just like to encourage everyone to start the conversation. When you are interacting with patients, trigger their mind, ask them, have they ever thought about what would happen if they couldn't make decisions for themselves or if they were too sick? It's good for us to start the conversation because that's where we will start heading towards having legislation in Kenya for advanced care planning. Thank you so much for sparing time. Until next time.
Thank you, everyone. And from me, communication is key in everything we do. What matters is how we say it and not what we say. And let us educate our clients and our patients and their families so that they're able to make difficult decisions even as they go through care. For now, it's bye-bye and God bless.